So hello everyone. Today I'll be discussing anatomy of orbit. So the orbits are the conical shaped bony structures placed symmetrically on either side of the sagittal plane at the root of the nose in the upper half of the face skeleton below the anterior cranial fossa and anterior to the middle cranial fossa. So इस डेफिनेशन को हमें याद करने के लिए हमें इस डेफिनेशन को 3 से 4 भाग में तोड़ना पड़ेगा, जिसकी वजह से ही हमें पता चल पाएगा कि इसके आसपास के स्ट्रक्चर से इसका रिलेशन कैसा है। तो सबसे पहले हम देखेंगे कि जो ऑर्बिट्स हैं कोनिकल शेप स्ट्रक्चर्स हैं और सेजाइटल प्लेन के दोनों सिमेट्रिकली साइड में पड़े हैं और रूट ऑफ द नोज के रूट ऑफ द नोज के पास है और अपर हाफ ऑफ द फेशियल स्केलेटन के अंदर है एंड बिलो द एंटीरियर क्रेनियल फोसा है एंड एंटीरियर टू द मिडिल क्रेनियल फोसा है। ठीक है, दो चीज़ों का हमें याद रखना है कि बिलो द एंटीरियर क्रेनियल फोसा एंड एंटीरियर टू द मिडिल cranial fossa. Then bony orbit is made up of 7 bones: the frontal, zygomatic, maxillary, ethmoidal, sphenoidal, lacrimal, and palatine. So as you can see in this image, there is a frontal bone, zygomatic bone, maxillary, ethmoidal, sphenoidal, lacrimal, and palatine bones which are constituting the orbit. Coming to the margins of orbit, so in this diagram roughly we can see there is a superior margin, medial, lateral, and inferior margin. So coming to the superior margin, so the superior margin is formed by the supraorbital arch of the frontal bone. Then the lateral margin is formed by the frontal process of the zygoma and the zygomatic process of the frontal bone, and inferior margin is made by the zygoma and the maxilla, and the medially it is made up by the processes of maxilla and the frontal bones. So coming to the ethmoid bone, medial orbital walls and lateral orbital walls, in this diagram we can clearly see the relation of orbits to the ethmoidal bone. So here we can also appreciate the ethmoidal bulla and the ethmoidal air cells. And so in the adults, the depth of the orbit varies from 40 to 45 millimeter from the orbital entrance to the orbital apex. An adult orbit has an average volume of 30 cc, with the globe volume being around 7 cc. So the first of all, we need to uh, get through the anatomy of the sphenoid bone because it is in the most closest proximity from behind to the orbits. And अगर हम इसको ध्यान से देखेंगे तो इसका स्ट्रक्चर एक ऐसा बोन की जैसा है जो कि आइस के जस्ट पीछे लगा दिया जाए। तो आप दोनों साइड्स में देख सकते हैं, दो सर्कल्स दिख रहे हैं जो कि कॉरिस्पॉन्ड करेंगे ऑर्बिट को पीछे से। ठीक है, तो सबसे पहले जो इसका सबसे सेंटर में जो पार्ट आता है वो आते हैं स्फेनॉइडल योक, स्फेनॉइडल क्रेस्ट एंड स्फेनॉइडल रोस्ट्रम। ठीक है, इन सेंट्रल रीजन्स के साइड में हमें दिखेगा एक स्फेनॉइडल साइनस एंड ओपनिंग ऑफ स्फेनॉइडल साइनस। ओके, देन एक स्फेनॉइडल कॉन्का दिखेगा हमें, जो कि तुम देख सकते हैं कि नोज की तरह लगेगा बीच में। और ये थोड़ा एलेबोरेटिव स्लाइड है स्फेनॉइड बोन की, जिसमें हम देख पा रहे हैं कि एक ग्रेटर विंग है और एक लेसर विंग है। देन देर इज अ बॉडी ऑफ स्फेनॉइड। सो हम एंटीरियर एंड पोस्टीरियर व्यू और सुपीरियर व्यू हमने तीनों देख लिए हैं। तो अब आगे हम बढ़ते हैं ऑर्बिटल रूफ पे। तो ये सारे जो भी स्ट्रक्चर्स हैं हम ऑर्बिट की बात कर रहे हैं, ये सारे बिना स्फेनॉइड को समझे हम याद नहीं कर पाएंगे, इसलिए मैंने स्फेनॉइड का पहले डाल दिया है सारा कुछ, ताकि अब इसको ध्यान से आप देख के सीख पाए। अच्छा, इसके बाद द ऑर्बिटल रूफ इज फॉर्म्ड फ्रॉम बोथ द ऑर्बिटल प्लेट ऑफ द फ्रंटल बोन एंड द लेसर विंग ऑफ द स्फेनॉइड बोन, द lacrimal gland and the fovea trochlearis. In this image you can appreciate the orbital roof, and this Cibria orbitalia are the small structures which are present on the orbital roof. Then ethmoidal air cells, as we discussed in the ethmoid bone that we studied before. And coming to the lesser wing of the sphenoid and the optic foramen and the superior orbital fissures. So these are the openings on the posterior aspect of the orbit. Then coming to the medial orbital wall, these are formed from 4 bones. So the frontal process of maxilla, lacrimal bone, orbital plate of the ethmoidal bone, lesser wing of sphenoid, lacrimal fossa, and lamina papyracea. Then coming to the orbital floor, the floor is made up of the following bones: the maxilla, palatine, orbital plate of the zygomatic bone. So there are infraorbital groove and inferior oblique muscle lying on the floor of the orbital. Then coming to the lateral orbital wall, these are formed from two bones. So the zygomatic greater wing of sphenoid. So this is why I taught sphenoid bone before the prior to teaching the walls of the orbit, because sphenoid bone constitutes a major landmark to understand the location of orbit. Then coming to the sinuses in close proximity to the orbit. So the front, so हम इसको एक इजी तरीके से याद करेंगे. तो फ्रंटल साइनस फ्रंटल बोन के पास रहेगा, आइस के ऊपर रहेगा, ऑर्बिट के ऊपर रहेगा, ठीक है. फिर आ जाएंगे हम स्फेनॉइडल साइनस पे, मैक्सिलरी साइनस और एथमॉइडल साइनस, ठीक है. तो स्फेनॉइडल साइनस कौन सा रहेगा, जो कि आइज ऑर्बिट्स के पीछे की तरफ रहेगा. एथमॉइडल साइनस ऑर्बिट्स के बीच में रहेगा. मैक्सिलरी साइनस ऑर्बिट्स के नीचे रहेगा. सो वी कैन रिमेंबर दिस दैट मैक्सिलरी साइनस लाइज बिलो द ऑर्बिट्स, स्फेनॉइडल साइनस लाइज before behind the orbits, ethmoidal sinus lies between the orbits, and frontal sinus above the orbits. So coming to the superior orbital fissure. So superior orbital fissure is located posteriorly between the greater and lesser wings of the sphenoid. It communicates with the middle cranial fossa. It transmits the lacrimal nerve, the frontal nerve, the trochlear nerve, the oculomotor nerve, the abducens nerve, the nasociliary nerve, and the superior ophthalmic vein. So it also traveling in the superior orbital fissure is the supraorbital division of the fifth cranial nerve, supplying sensation to the forehead and the lacrimal nerve. The parasympathetic and sympathetic innervation to the eye also passes through the superior orbital fissure. Coming to the inferior orbital fissure, in the diagram we can see the inferior orbital fissure just near to the superior orbital fissure. So it is located posteriorly between the maxilla and the greater wing of the sphenoid. It communicates with the pterygopalatine fossa. It transmits the maxillary nerve and its zygomatic branch, the inferior ophthalmic vein, and sympathetic nerves. So the inferior orbital fissure begins anterior to the foramen rotundum, through which the infraorbital nerve courses. Then coming to the contents of the orbit, so here we can see that there is an eyeball, extraocular muscles, nerves, blood vessels, lacrimal gland, and fat. So I have made this orbit as a cone on the right side. So we will be discussing the orbit as three parts of the pyramid, or the triangle I have made. So the orbit is a conical structure, the apex of which points posteriorly. So the lower part you can appreciate the apex, which denotes the posterior aspect. Then coming to the base of the cone, so the base is bounded by relatively thick bone, contributing to both the vertical and horizontal facial buttresses. It is useful to divide the orbit into anterior, middle, and posterior thirds. So I have made three lines on the right side of the cone, which denote the anterior, middle, and posterior thirds. Then coming to the anterior third, it is comprising of a thick orbital rims and is fractured in association with facial fractures such as LIFO2, nasoethmoidal fractures, frontal sinus, and ZMC fractures. A pure fracture of the orbital rim is an unusual and rare occurrence. Then coming to the middle third of the orbit, that it comprises of the thin bone of the lamina papyracea, orbital floor, roof, and the orbital plate of the greater wing sphenoid. This portion of the orbit is subject to injury in association with the named fractures listed above, as well as pure blowout fractures resulting from rapid increases in intraorbital fracture. The majority of blowout fractures affect the floor and medial walls of the orbit. The lateral orbital wall is also subject to medial impaction resulting from forces directed to the lateral orbit. So coming to the posterior third of the orbit, which is made up of the stout bone of the lesser sphenoidal wing and the body. So, the fractures of this area require considerable force and frequently are associated with injuries to the orbital contents, including the orbital optic nerve and intracranial contents. The posterior orbit serves as the portal of entry from the intracranial cavity for a number of cranial nerves, most importantly, the optic nerve, which passes through the optic canal formed in the lesser sphenoid wing. The nerves to the extraocular muscles, cranial nerve 3, 4, and 6, pass through the superior orbital fissure, which is located between the lesser sphenoid wing and the orbital plate of the greater sphenoid wing. Then coming to the fascia, so we have two kinds of fascia in the orbit. So one is the orbital fascia and the other is the bulbar fascia. Coming to the orbital fascia, it forms the periosteum. In this image, you can appreciate that there is an periosteum coming from above, both and from the below. Both are the or walls of the orbit on the like this one. I am talking about the anterior third component of the globe. Okay, so then the periosteum continues as an orbital septum. Then orbital septum lies in the crow's proximity with the tendon of levator palpebrae superioris muscle. Then coming to the bulbar fascia. So the bulbar fascia comprises of Tenon's capsule, medial check ligament, lateral check ligament, and it forms the sheath around the muscles. So we will be discussing these structures in detail. Then coming to the Tenon's capsule. So it is a bulbous sheet as discussed earlier. From bulbar fascia, we will be checking it as a bulbous sheet, which is a fibrous layer between the eyeball and the intramuscular orbital fat that is interspersed between the six muscles of extraocular movement. Then it attaches to the sclera on the anterior and posterior surfaces of the eyeball. It covers the eyeball from the optic nerve as far as sclerocorneal junction. So you can see in this image, we can appreciate a Tenon's capsule on the posterior aspect of the eyeball. Then coming to the septum orbital. So septum orbital is a loosely attached layer of skin. It extends from the tarsus of the orbital rim, where it then attaches to the bone and becomes the periorbita inside the orbit and periosteum outside the orbit. It separates the orbita contents with the lid contents. So the major purpose is to contain the spread of infections. Coming to the tarsal plates, in the lid margins, there are thick pads of dense connective tissue called tarsal plates. Then here we can appreciate in this diagram that the lower aspect of the eyeball, there is tarsus, and on the right side we have tarsal strap and Whitnell's tubercle and a large superior tarsus, upper eyelid, small inferior tarsus is the lower eyelid, and within the tarsal plates, we there are large sebaceous glands called the meibomian glands, which empty into the free margins of each eyelid. Then coming to the periorbita. So as the optic nerve traverses the optic canal, it is surrounded by dura, which then attaches to the bone of the orbit. Wherever the cranium comes in contact with the orbit, the dura becomes continuous with the underlying bone, and this corresponds to the orbital periosteum. Then, periorbita thickens and gives rise to the tendinous attachments, also known as the annulus of Zinn, on the medial side of the superior orbital fissure and on the orbital surface of the optic canal. Okay, you can refer this diagram to understand in detail for the annulus of Zinn. Then, coming to the suspensory ligament of the lockwood, so it is a fascial sling which blends with the lateral canthus and traverses from the lateral to the medial, suspending the globe and resisting the anterior and posterior displacement of the eye. Coming to the Whitnell's ligament, so it is a fascial sling extending from the trochlea to the lateral orbital wall. Here in the image, we can appreciate a white line running above the levator aponeurosis and below the levator palpebrae superioris muscle, connected to the trochlea on the left aspect. Then coming to the extraocular muscles. So there are four recti and two oblique voluntary muscles and one levator palpebrae superioris muscle. So the four recti muscles include the superior rectus, inferior rectus, medial rectus, lateral rectus. Two oblique muscles constitute of the superior oblique, inferior oblique. The involuntary ones include superior tarsal, inferior tarsal, and orbitalis. Okay, so in this diagram, we can see that the various muscle attachments to the orbit. So this is a 3D cross-sectional diagram. So the eyeball contents have been removed from the center in this image. Here we can appreciate all the muscles which are related to the orbit. Coming to the voluntary muscles, so the origin all recti. So the voluntary we had the rectus and the oblique muscles and the levator palpebrae superioris muscles. So the origin is so origin all recti from the tendinous rings, lateral rectus also from the orbital surface of the greater wing of sphenoid, and then we have levator palpebrae superioris from the orbital surface of lesser wing of sphenoid. Then superior oblique muscle we have origin from the orbital surface of body of sphenoid, and inferior oblique from the orbital surface of the maxilla. Then insertion of all the recti muscles behind the limbus at various variable distance, and oblique muscles behind the equator, and levator palpebrae superioris into the skin of eyelid, anterior surface of the tarsus, upper margin of the tarsus. Then this is an easy diagram which we can be using. So these extraocular muscles are just from a different view of this diagram. Looking from in front and removing the eyeball contents, we can get this diagram. So coming to the next slide. So we will be discussing the action of various muscles and movements produced by them. So taking the eye as a 3D ball-like figure, we can easily understand these actions which are displayed on the right sides. So elevations means ऊपर उठाना, depression मतलब नीचे जा रहा है. ये aspects हैं सारे ऊपर नीचे, मतलब superior, inferior, medial और lateral. एंड ये हम रेड और येलो में जो एरो देख रहे हैं एक्सटर्नल और इंटरनल रोटेशन के एरो हैं. एबडक्शन और एडक्शन. सो एडक्शन मतलब मीडियली लेके जा रहे हैं, एबडक्शन मतलब हम लेटरली लेके जा रहे हैं. देन coming to so this diagram is very important. The diagram on the left side is very important for understanding. So coming to the oblique, and we will start from inferior oblique. Okay, so inferior oblique will give an above elevation, upward side, and superior rectus will also give an upward side. So the always remember that the oblique muscles will always, the superior and inferior oblique muscle will act opposite as compared to the superior rectus and inferior rectus. So if inferior oblique muscle is acting, so it will be acting opposite as the superior rectus muscle. Okay, so these are the various diagrams from which we can understand the actions of different muscles. Then the nerve supply of extraocular muscles. So the three cranial nerves which supply the extraocular muscles. So the third cranial nerve, oculomotor nerve, the medial rectus, inferior rectus, superior rectus, inferior oblique muscle. So we can remember the rest muscles as SO4 and LR6. So the SO4, the superior oblique muscle, is supplied from the trochlear nerve, and the abducens supply the lateral rectus, LR6. Okay, so now coming to the oculomotor nerve, it supplies the extra as well as the intraocular muscles. It enters the cavernous sinus by piercing the posterior aspect of its roof. So the nerve divides into two divisions, which never enters the orbit via superior orbital fissure. Then the upper division supplies the superior rectus and levator palpebrae superioris. The lower division supplies medial rectus, inferior rectus, and inferior oblique. So so the upper division, the upper division had a senior, okay. So the senior had a beautiful girlfriend known as the levator palpebrae superioris. So these are supplied by the upper division, and the juniors, MR, IR, IO, these all the small juniors, but supplied by the lower division, poor juniors. Then coming to the nerve, to the inferior oblique, which supplies the parasympathetic fibers to the ciliary ganglion. Then coming to the optic nerve, so it is a second cranial nerve, as you all know. Then it is the nerve of sight. It starts from the axon of the ganglionic cell layers of the retina. It emerges from 3 to 4 centimeter nasal to the center of eyeball. So please, please, everyone, it is a request from my side to note down all these diagrams in detail in your own handwriting, so that you can cover most of your exam sheets with these diagrams, and the examiner also gets happy after checking your exams. And then coming to the outer eye, we have eyelids, the which so the extension of the skin from the forehead and cheeks spreading over the inferior and superior aspects of the ocular globe represents the upper and lower eyelids. The separation of two eyelids is called the palpebral fissure, widest at the midpoint of the pupils. In the right side diagram, we can see the 10 mm one. It is the widest point at the middle of both the eyelids, where the palpebral fissure is the widest. So the separation, so the only a thin layer of connective tissue separates the skin from the underlying muscle layer. Hence, it may account for accumulation of blood when an injury occurs. The eyelid fulfills two main functions: protection of eyeball, secretion distribution, and drainage of the tears. So this is a diagram which clearly demonstrates the caruncle, medial canthal angle, plica semillunaris, superior eyelid crease, and lateral canthus angle. The lid structure and movement. So this diagram is very important for representation in the exams. The levator muscle extends from an attachment at the orbit apex to attachments at the tarsal plate and skin. The lids are securely attached at either end to the bony or vital margin by medial and lateral palpebral ligaments. So, what are the layers of eyelid? So, eyelid layers from superficial to deep include the following: skin, subcutaneous areolar tissue, striated muscle of orbicularis oris, oculi, then submuscular areolar tissue which contains the sensory nerves, tarsal plates with a fibrous layer, non-striated smooth muscle, and the conjunctiva. Then coming to the eyelid muscles, so the starting from the upwards, we have frontalis muscle, which is indirectly related to this eyelids. Then coming to depressor supercilii muscles, which lie on the medial aspect of the eyelid muscle. Procerus muscle is a continuation of the frontalis muscle running downwards towards the nasal bone. Then anterior arm of the medial canthal ligament. So the left side, we can appreciate the orbital portion of the orbicularis muscle, superior preceptal portion of the orbicularis muscle, and the superior pretarsal portion of orbicularis muscle, and lateral horizontal raphe. Coming to the orbicularis oculi muscle. So orbicularis oculi muscle is present in the superior and inferior lids, so palpebral portion, and lies just below the skin. This muscle has a palpebral and an orbital component. So coming to the lacrimal system, so it is involved in production, movement, and drainage of fluid from the eyeball surface. It consists of lacrimal gland, lacrimal passage, lacrimal puncta, and lacrimal canaliculi, lacrimal sac, and nasolacrimal duct. Coming to the nasolacrimal canal, so it is located anteriorly on the medial wall. It communicates with the inferior meatus of the nose. It transmits the nasolacrimal duct. So, as discussed earlier, the tears move from lacrimal glands, lacrimal ducts, conjunctival sac, lacrimal punctum, lacrimal canaliculi, lacrimal sac, nasolacrimal duct, inferior meatus of the nose. So, the tear production, the lacrimal gland secretes most of the aqueous component of the tear film. So, its location is on the supratemporal part of the anterior orbit, and innervation is parasympathetic fibers carried by the facial nerve. So it is arterial supply is from the extensions of the internal carotid artery via the ophthalmic artery. In the orbit, it gives off lacrimal artery, which supplies lacrimal gland, muscles, and lateral side of the eyelid, central retinal artery. Coming to the venous drainage, is via the superior and the inferior ophthalmic vein running through the superior orbital fissure. There are also communications with the facial vein and pterygoid plexus of veins via the infraorbital fissure. So, coming to the sensory innervation, which is from the trigeminal, the fifth cranial nerve via the ophthalmic division, upper lid, and the maxillary division, lower lid. So, the orbicularis oculi is innervated by the seventh cranial nerve, and the levator muscle in the eyelid is supplied by the oculomotor nerve. Coming to the lymphatics, so the lymphatic fluid drains into the preauricular and submandibular nodes. So the preauricular lymphadenopathy is a useful sign of infective eyelid swelling, especially viral one. Thank you.